micronutrients that have been studied or that have been researched about that are more or less protective, or they are more predisposing to the development of COPD in adulthood. Thank you.
I'd come across vitamin D deficiency and also folate deficiency that actually that predisposed you to development. It was more of chronic diseases rather than just chronic obstructive lung disease, because it was a risk factor for also developing heart diseases, hypertension, and even diabetes as part of the Baker's theory. So for them, they were focusing more on vitamin D and folate, where there's a study, I can't remember the name, where they're done vitamin D supplementation and folate supplementation that showed a risk reduction in the chronic diseases. But Dr. Marangu can add on that.
Thank you.
Brian, you want to say something? I see you've made a comment. Please look at Baker's hypothesis.
Yeah. As I was going through Baker's hypothesis, I was saying that when you look at the first 1,000 days of life, if we don't want to look at Baker's hypothesis, let's just look at the first 1,000 days of life. That whole documentation. There are some studies that are done, because it doesn't just involve COPD, the Baker's hypothesis. It has shown that the early nutrition for things like type 2 diabetes, is it type 2? Yes, type 2 diabetes, heart disease, hypertension, these are things that have proven. But things like asthma, also things like atopic dermatitis, these are all things that more studies need to be done to actually show the link. But they're saying that diet does and can influence whether or not you'll get these diseases later on. I think that's it on my side. We just need to, let's go over Baker's hypothesis a little bit more, and it should be able to give us more insight.
Okay, Edith, do you want to unmute yourself and ask the question about your BPA and plastics? Dr. Ogada? So she asks, with regard to BPA for manufacturing plastics, is it advisable not to use plastic material when feeding?
I would avoid plastics. A lot of studies are being done. I think we didn't really focus on looking at plastics and the effects that they have on the system, but the more studies are being done about plastics, especially this when you put them in things like in the microwave, and all what Dr. Marangu was saying about these particles that are very, very small in diameter, and how you can inhale them or ingest them. They don't only affect with your lungs, but also other systems can be affected by plastics. These are studies have been done. They have shown this. Unfortunately, we are not so sensitized in our setting in third world countries. So I think we also need to look more into studies about plastics and the type of containers, because in Kenya, in KEBS, you don't, when you buy a plastic container or your food is packed in a plastic container, you're not exactly sure what kind of plastic the container is in. Whereas in Europe and other places like in the States, you must, usually is an indication of which plastics can be used. They also have very good regulations on plastics, because of they've been seen to be carcinogenic and they cause various chronic illnesses.
Yeah, so also for the microplastics, as he has also alluded to, you can get those microplastics from rubbing against whatever you're using to feed the baby or the toys that they're using, so that they can inhale. When they inhale them, then they can lead to now a risk of getting either respiratory or cardiovascular diseases, and also at a risk of getting cancer.
Thank you. Emma and Esther, Emma Mwaura, Esther Matu, I see you've raised your hands. Do you want to unmute? Maybe start with Emma and mute your microphone and ask the question.
Okay, so my question, there are this, we have children sometimes who have mild symptoms of allergy or asthma that we tend not to, let me just use the word ignore. We tend to ignore because maybe you don't see it like having a big, like actual does not interfere with their work, with their playing and a normal life. But then now looking at this theory of this asthma leading to COPD, does that mean that we need to manage even the mild symptoms, especially children who are about 1, 2, 3 years old?
Not just only for COPD, but for the patient themselves. We need to identify asthma early. Asthma will be the next talk. I think will be facilitating you. Asthma is a chronic lung disease.
Okay.
Yeah, it's just that the obstruction is reversible, and it's postulated that it could have effects even in terms of now being maybe irreversible later on in life. But when we, strictly speaking, when we're talking about asthma, I mean, when you identify it early, you should treat it. And we know now the mainstay of treatment is inhaled corticosteroids, yeah?
Steroids,
to inflammation. When you find early disease, you want to manage appropriately and give children control so that they can be able to play and go to school and do all the things they need to do to become doctors and everything else they want to be in their lifetime in the future, okay? So, and then that was the simple roundabout. Sorry, I hijacked that question, Brian and Rosie. Esther, your hand is up.
Yes, my hand is up. My question would be on, I've met a lot of COPD patients who have developed COPD not only because of smoking, but mainly because of the traditional methods of cooking. That is cooking with charcoal, and yes, basically cooking with charcoal. How does that play into our discussion today?
When you are talking about the exposure to environmental chemicals, one of the main sources that we mentioned was biomass and traffic emissions, and part of using the charcoal and kuni is part of the sources of that. And that's why you'll find a lot of the adults, most of them have COPD, but it's because of exposure to biomass rather than smoking.
Thank you, Rosie. And we'll see this a lot in our grandmothers presenting with COPD and later on having to be on home oxygen. So there's a question that I saw a bit earlier on. I want to tie this with, was it Dr. There's someone who talked about oxygen. Yeah, it was Dr. Nick Mutisia. Are there effects on lung morphogenesis by the routine use of oxygen in the wards? Nick, is it possible that you unmute your microphone and just elaborate on your question?
Hi, everyone. Thank you for the good presentation. So my question is on the use of oxygen. Many are times that you find, if you check the saturation of the baby and the oxygen that you are giving, most of the times that we are on the higher side. So has there been found any effect on this use of oxygen, this routine use of oxygen in the wards, in the morphology, and maybe in the future, having this lung complications in future?
So if I got you wrong,
Okay.
Go ahead, Brian.
So mine is just brief, and then Dr. Marangu can add. Remember, oxygen, if used in excess, is toxic. So oxygen can actually be toxic, and this toxicity, I am assuming, could lead to different lung changes, remodeling as well. So in essence, if the oxygen is the cause of the inflammation, then yes, we can, given the studies and given the theory, we can say that if you're having too much oxygen that's causing toxicity, then it can.
And we've learned a lot of this, especially from neonatal medicine, and even seeing it just beyond, not the not just oxygen toxicity towards the lung, but also to other organs, including the eyes for children, and retinopathy of prematurity. That is one of the underlying mechanisms.
I have a question. I received a question. I don't know if everyone has seen it, from Dr. Twafle, because it's written privately. So she's asking about breastfeeding. She says breastfeeding has shown to protect against respiratory infections in childhood and may indirectly protect against chronic lung disease. Does this beneficial effect persist beyond the age after which breastfeeding has been weaned off? And is there any recommendation on duration of breastfeeding or weaning off with regards to prevention of respiratory infections later in life?
Go for it, Brian.
Okay, so recommendations, WHO recommends that you exclusively breastfeed for at least a minimum of 6 months. I've also been talking about the first 1,000 days of life. If you Google the first 1,000 days of life, there's also literature about the benefits of breastfeeding. It's also a question in pediatrics, a very short answer question in pediatrics about the 10 successful steps to breastfeeding. So science has proved that if you do at least the first 6 months of breastfeeding, it will help in preventing respiratory infections. Breast milk also contains a lot of immunoglobulins in infancy, which protect the infant against various respiratory infections. It has actually, studies have shown it reduces the chance of babies being admitted or hospitalized because of things like RSV or pneumonia, bronchiolitis, and the likes. The other thing was when you should wean off. So the 6 months is the cutoff, but you can continue breastfeeding until 2 years of age. However, after 6 months, it is recommended that you must start weaning. This is because breast milk at 6 months is not sufficient enough to handle the caloric requirements for normal growth and development of the infant. So at 6 months of age, you breastfeed, but you top up with weaning so that you can meet the right caloric requirements for normal growth and development, both neurodevelopmental and the muscular development.
So, Brian, the only thing I want to add, and Rosie, you can comment, it's just terminology. Remember, weaning, strictly speaking, I know how we use it colloquially, but weaning means cessation of breast milk. And I think more the correct terminology is introduction of complementary feeding. Yeah. So as you said correctly, at 6 months. And this, I'm tying it to a question, I think for Stephanie, about allergen exposures. So when people have been delaying, giving peanut or giving so-and-so food, as Brian has said correctly, the introduction of complementary feeds, starting with the feeds that are available in your home, including that groundnut or whatever it is, but of course introducing it, and we know how we introduce complementary feeding, actually has been useful in understanding this role of allergen exposure and contribution to, actually getting very severe allergies, or even its contribution into asthma. So when you do it too early, before 6 months, that is not a good idea. And also when you do it too late, if you're very afraid to introduce this antigens, which may be allergic, depending to the person who's sensitized to them, may also not be a good thing. So it's the right balance. And as Brian correctly said, it's important to introduce complementary feeds timely. Rosie, did you want to say something about breastfeeding?
I don't think I have anything additive because I think I'll go with the 6 months.
Yes.
And yeah, I don't think I have anything else to add on that.
Some studies would say 4 to 6 months, but we know our WHO guidelines, and what we follow is 6 months. So exclusive breastfeeding for 6 months, as Dr. Brian has explained to us, then now introduction of complementary feeds thereafter, and not fearing introducing these feeds, but doing it in a systematic way. When you avoid the children we have seen lots of peanut allergy, they were not introduced to this in a timely way. and then they get, when introduced much later, they tend to not react to it very well. Another maybe comment, maybe the comment I just want to make as Brian and Rosie think of their final remarks. For me, one of the earliest chronic lung diseases, and I think we've discussed it, and Brian and Rosie explained very well, is bronchopulmonary dysplasia. And they've alluded to it, to this condition, especially from prematurity and low birth weight perspectives. So we normally don't look at bronchopulmonary dysplasia as a chronic lung disease, but actually that's one of the earliest chronic lung diseases that we experience in pediatrics and neonatology. Then of course, asthma is a very common one in pediatrics. This is a chronic lung disease. It's just that it is reversible and there are different phenotypes, which we're going to discuss in the later discussion. And then most of this talk was really pointing towards, but it's interrelated to chronic obstructive pulmonary disease later in adulthood. So I think I'll give the floor back to Brian and Rosie, and then maybe if Prof. Bimbo is still online or Dr. Metra is online, they can make a comment. Thank you.
Ladies first.
Okay. I think what we wanted to talk about in this today's topic was especially for the internal medicine, the physicians, that we have a role in especially in talking to patients with COPD, so that we also get a good history on the risk factors, so that we also can see how we can play a role in the prevention and also in the screening, so as to reduce the deaths, because it's one of the I saw in one of the studies that it indicated one of the top causes of mortality in respiratory diseases. So for us, what we need to know is the role of genes in COPD and any other chronic lung disease, and also the environmental exposures, where you have your environmental chemicals, your maternal smoke, and diet, and also the other thing we didn't indicate here was premature babies, as we had talked about in lung morphogenesis. We noted that it has the 5 phases. So if a baby is born less than 36 weeks, you see you'll be in your circular phase. You won't have completed your alveolarization. So that will also be one of the risk factors. So yes, that's from me. I think Dr. Mwendo can add.
Okay. Thank you, Dr. Rose. So thank you everybody for listening. Thank you for all your questions. It's been quite interactive. Just to highlight, we've already mentioned, we will share the stages about embryology and also the 5 stages of the lung development. Other than that, yes, it's to tell the physicians. Remember, there was a chat about tobacco. In Africa, we seem to be least in tobacco smoking, except for Northern Africa, where it's very high. So for the internal physicians, just because somebody might not have a smoking history, this is just to highlight that you should not rule out COPD because of all the early developmental changes that can lead to it. So that's what we want to highlight. And also for the pediatricians, I think to highlight is it's important for us to think about nutrition. So let's go over Barker's hypothesis and how we can help kids not develop COPD in the future, and how we can talk to pregnant mothers and advise them accordingly about nutrition. And then also about managing, the things like asthma and respiratory infections, not thinking about it acutely, but also thinking about the effects that these infections have in the future.
Absolutely, and I know your Prof. Bimbo is going to take you for other chronic lung diseases, including bronchiectasis and bronchiolitis obliterans, which have the roots in what we've talked about. You'll also talk about interstitial lung diseases, which they're also there are elements that we have talked about that will contribute to that. So all this is interlinked. And at this point, it's the time now. I think we've extended our time. I'm really sorry. I want to thank everyone, especially Dr. Rosie and Dr. Brian, for their excellent presentations. Is Prof. Obimbo still online?
Yeah, hi everyone. Hi everyone, can you hear me?
We can hear you,
Yes, we
Prof.
can.
Okay, I came on a little bit late. I was kind of having Wi-Fi issues, but the bit of the talk that I heard was really, really fascinating. I think you guys covered the topic really well. Maybe just one to help answer one of the questions about the exposure to pesticides and lung function. So the answer is yes. There's evidence that exposure to various pesticides does affect lung function. So those, especially cholinesterase, those which contain cholinesterase inhibitors like organophosphates and carbamate insecticides. So these actually cause reductions in the various parameters of lung function, mainly causing obstructive airway disease. Then some of the pesticides also have an effect on the membranes and the interstitial tissues, causing some pathology even in the interstitial. So if you think of a mother, like the one in our setting, maybe you can think of those working in flower farms or some of these huge plantations where they are continually exposed to pesticides. I'm sure this is a great opportunity to, and there may be studies out there that show effect on their newborns and their lung function. But it would really, I don't think there's really much evidence to actually link the two. Yeah, but from other countries, there's that evidence. So PPEs for our farm workers, for our women who are working in factories where they may be exposed to these kind of chemicals or even other chemicals is required. And I speak to the internists. There's a lot of prevention that can happen by really identifying women who are at risk from their various environmental exposures and maybe empowering them. Maybe they can live away from the factory, or they can, or educating them on, getting the N95 type masks.
Prof, I think we lost you.
Just like to hear. You guys often do really good research, and for me, it's a good sort of revising and updating on some things that I knew. So thank you.
Okay, there being no other questions, and I think, or do we have one more last one? Let me see. There being no other questions, and again, once again, Brian, Rosie, excellent presentation. Thank you, Prof. Obimbo, for sharing those comments. We really appreciate you creating this series for us in RESP, and we hope to continue learning more during this series. Thank you, everybody, and have a good afternoon. Bye.
You too, Doc.
Good afternoon, everyone. Stay safe.
Good afternoon.
Take care.
Bye.